for the conference. So if you are feeling anyway uncomfortable about that, or don't want to be seen on it, do ensure to keep your video off as we go through. Okay. So sorry, just there's a little delay on my slides. Moving on here. So today, where you can see we're on day 3 of the conference, building on an excellent start from Tuesday. Yesterday was another great great session with real learnings and practical insights shared by Andrew, Enrique and Amanda in relation to both the recruitment for programs and also the intervention design process around Move for Life. And this was followed by another really practical and interactive session delivered by Kira and García on measuring PA physical activity, whether that is in the context of monitoring program outcomes or for research purposes. So it was a really insightful and informative day. Today we are I think very much focusing on looking forward and where the Move for Life research project and learnings can take us, with the first session chaired by Dr. Ali Shiki, looking at the feasibility and evidence of promise from the research presented by Professor Catherine Woods and Enrique. And then in terms of the health economics evaluation that was conducted, we'll have Professor Paddy Gillespie from NUIG sharing insights from that. Throughout the session, as in on the last few days, we'll hear snippets from the participant, researcher and tutor voice, which have all been really instrumental in shaping this this research. The second session this afternoon and the last of the conference is very much going to be taking a practical look from the perspective of the LSP network, and that will be chaired by Benny Cullen, who's the Director of Research with Sport Ireland. So really exciting day ahead of us, or a couple of hours ahead of us today. So I'm just going to do a little bit of scene setting, and again, for those of you who have been here for the last 2 days, there will be a little bit of a repetition. Hopefully it won't put you to sleep. The focus of, I suppose, the context for our work in relation to positive aging is very much that the growing older population is one of the most significant challenges for us in Ireland and across Europe in terms of our society and in particular our healthcare provision. The proportion of the population in Ireland is age 65 plus is expected to double over the next couple of decades, and those aged 80 plus will quadruple on the baseline from 2011. And I suppose importantly, from an individual and societal perspective, what is important for us is how we plan to ensure that everyone continues to have a good quality of life for as long as possible throughout their later years. All of us will know older people and older adults who have who are happy, healthy, engaged and contributing to society, and the biggest challenge is how we ensure that this is the case for the majority of our population. The National Positive Aging Strategy is the main policy and strategy that guides our work in this area. It was published in 2013, but it is still a live document. It sets out a vision for a society that celebrates and prepares properly for individual and population aging, that enables and supports all ages and older people to enjoy physical and mental health and well-being, that promotes and respects older people's engagement in economic, social, cultural, community and family life, importantly, fostering a better solidarity between the generations, and also a vision of a society in which the equality, independence, participation, care, self-fulfillment and dignity of older people are pursued at all times. And those of you who were here with us on Tuesday will have heard a really interesting presentation from Mary Harkin in Age and Opportunity around research conducted as part of COVID, which was probably very insightful in terms of how the vision of the National Positive Aging Strategy was lived over the last 18 months of the COVID-19 emergency. For those of you who weren't here on Tuesday or yesterday, those sessions have been recorded, so you will be able to listen back to them. The Positive Aging Framework is a next step in implementing the vision. It focuses on, sets out 4 broad goals. Goal 1 focuses on removing barriers to participation and providing more opportunities. Goal 2 is around supporting people as they age to maintain and improve or manage physical and mental health and well-being. And goal 3 is around enabling people to age with confidence, security and dignity in their own homes and communities for as long as possible. Goal 4 is a cross-cutting theme, and all the goals really work together to create this overarching society where we can all age as positively as possible. But in terms of goal 4, the cross-cutting theme there and the element of it that really connects to the Move for Life research and the work that we're sharing today is a focus on timely and regular access to comprehensive information about all determinants of health, well-being and quality of life. So one of the initiatives to implement the both positive aging strategy and framework was a collaboration between the Department of Health, HSE, Age Friendly Ireland and Atlantic Philanthropies called the Healthy and Positive Aging Initiative. The initiative started back in 2014. It has come to a conclusion now, and the presentation of this conference today is probably the final step in that project. But over those number of years, it had 4 key strands: establishing a set of key indicators for older persons' health and well-being using existing research and data, publishing a biennial report on health and well-being of older people, and also a series of county reports which focus on disaggregating national indicators to local level, and those are all available online or being used in practice by our age-friendly networks. The 4th strand of it, or second in the bullets here, was to establish a research fund to commission targeted once-off research to fill data and knowledge gaps relevant to the design or configuration of future services and supports for older people. In 2015, a healthy and positive aging for all research strategy was published, and there were 2 research calls under that. The first one, the research projects that were funded looked at dementia inclusive design for hospital spaces, looked at what we could learn in terms of the life course and structural determinants of positive health for older adult travellers and homeless people. And the 3rd one was around understanding inequalities in palliative care for older people and providing for future need. The second research call focused solely in relation to physical activity for older people, and the research project, the one research project funded there was the Move for Life project, which you're going to be hearing more about today and have done over the last 2 days. So when we were looking at the Healthy and Positive Aging Initiative, I suppose, and the research calls, the question is why the focus on physical activity. So we know that only 38% of our older adults are meeting the national guidelines for physical activity. We know that the rate of long-term illness increases with age, with the majority, over 61% of adults aged 50 plus, having a chronic condition such as arthritis, osteoporosis, cardiovascular disease, respiratory conditions and diabetes. And we also know as people progress from 50 through the decades that more and more people are living with 2 or more of those chronic diseases. Significant evidence exists both at an international and a national level to show that meeting the National Physical Activity Guidelines promotes well-being, physical and mental health, prevents disease, improves quality of life, and has economic, social and cultural benefits. And indeed, the Royal College of Surgeons in Ireland have coined the term a wonder drug for physical activity, primarily because of the significant impact it can have in terms of reducing the risk of developing disease and illness, but also because of its benefits for people who are living with chronic disease. So you can see why it would have been one of the priorities and focuses in terms of the Healthy and Positive Aging Initiative research goal to look at how we can improve participation rates in physical activity. So while the benefits are many and very well known, we know that the increasing physical activity levels at a population level continues to be a challenge. The Lancet series on physical activity in 2016 observed that while many countries have adapted national policies and action plans to improve physical activity, implementation remains weak, and implementation is the critical piece, because that is the element that delivers the impact at a population and an individual level. It was theorized there, the Reset Al theorized that the greatest progress in addressing this challenge is likely to occur through interventions that are effective in promoting physical activity, implemented at scale, regularly assessed and fully embedded in an enabling system. And that's really what the Move for Life study set out to do, to develop a community-based intervention that would address the problem of inactivity, be easily implemented and embedded within the existing system, designed for the promotion of physical activity in adults living in Ireland aged 50 plus. And the session this afternoon, we're looking at through the lens of the Local Sports Partnership, will be really interesting, because the Local Sports Partnership network is a significant part of the enabling system for physical activity in Ireland. So the key questions that the study set out to answer, the research team working with the collaborators, the stakeholders and the local community, were: how do we enhance the effectiveness of the existing physical activity programs in increasing physical activity in inactive population aged 50 plus? And how do we broaden the reach of these programs to more participants and make them sustainable in the long term? And it was hypothesized that the Move for Life program would work by empowering both professional and non-professional members of the community, using a cascading model to teach behavioural skills and provide informational and social support. And the little graphic here to the side just tries to illustrate the potential impact and reach that the Move for Life project was aiming to achieve. The research team would have used a 6-step intervention mapping process in developing the research, and Catherine and Enrique will have stepped you through, or the presentation yesterday will have stepped you through some of that work. The research was carried out in 4 strands. Strand 1 was around understanding the evidence. Strand 2, developing the intervention. Strand 3, testing and evaluating it in the real world scenario. And Strand 4, which we're in now very much, is sharing the learnings. This is the research team here. There are members from University of Limerick, National University of Ireland in Galway, Limerick Sports Partnership, Clare Sports Partnership, Age and Opportunity, and the HSE. So you'll recognise many of those faces throughout the session today. The project was, or the research was launched in UL on the 30th of April by the president of UL, University of Limerick, Dr. Desmond Fitzgerald, and the Minister of State at the time, Catherine Byrne. And here in this image or this picture, you'll see the number of the tutors and peer mentors from across the 2 counties, Limerick and Clare, and the 8 sport and physical activity hubs in the region that participated in the project. So part of the project was training up tutors and peer leaders to demonstrate and test that cascade model. So as part of the research and the evaluation, testing and physical activity assessments were carried out over the period May to September 2018, and Ciara and Grania yesterday will have given you some insight into the various tests that were used across that period. And this very much took place in the community halls and inside and outside in community facilities, supported by the research team, students from UL, volunteers from the Local Sports Partnership and the HSE. So all that help was greatly appreciated. The Move for Life project itself, over 733 adults aged 50 plus took part in it, and their experience and their insights and their contribution has been really valuable. As I mentioned, we're in strand 4 of dissemination now, but this work had been ongoing over the period of the project as well, with the research team presenting at a number of conferences. And there have been a number of papers published in peer-reviewed journals, many of the academic sessions today, yesterday, and on Tuesday are based on the published papers. And also we have a mini documentary that you've been seeing snippets of over the past 2 days, and will again today, that was produced by Missy Knowles and Trevor Ferris, which is a real example, I suppose, of public participation in research. This is just the research team again, delighted. I'm not sure was this at the start of the project or at the end, but also wanting to say a big thank you to all the Move for Life participants, tutors, funders and researchers. And as PI, Catherine Woods is, her contact details are there if anybody wants to follow up. So just before I hand back over to Ciara and the next session, just on behalf of the HSE, the Department of Health and Atlantic Philanthropies funders for the initiative, I'd like to say add my thanks to that of the research team, to the participants, to everybody involved in the research, the team themselves and all the various collaborators and stakeholders. So it's been a fantastic project, and the conference to date has just been a great opportunity to share all that really good learning and practical experience with everyone. So thank you very much.
Yep, thank you, Sarah. So we're actually going straight away, conscious about time, to our session. So you're very welcome to the last day of the Move for Life conference. We have a very interesting lineup of talks and speakers actually today, this afternoon. So first, Professor Catherine Woods and Dr. Enrique García are going to take us through feasibility and evidence of promise. And these are results from Move for Life study. And after that, Professor Paddy Gillespie is going to talk about health economics evaluation of Move for Life. So I'm going to introduce our speakers today very briefly. Professor Catherine Woods is interim program director of the recently established Physical Activity for Health Research Cluster in UL's Health Research Institute. Previously, she held the position of chair in Physical Activity for Health in the Department of Physical Education and Sports Sciences. Professor Wood's research cuts across the HRI theme of lifestyle, health, and technology. She enjoys developing and testing theoretically sound interventions to change population levels of physical activity and seeks better, more systematic methods of bringing research, practice, and policy closer together to achieve real and sustainable impact. Professor Woods believes that physical activity is a best buy for public health, as it has the potential to improve health and well-being for everyone, irrespective of age, ability, or condition. We also have Dr. Enrique García with us today. Enrique is currently a coordinator of the Irish Physical Activity Research Collaboration with the Sport Ireland. He's also a researcher affiliated with the Physical Activity for Health Research Cluster of the Health Research Institute at the University of Limerick. His main research interests are physical activity promotion, the social determinants of health, participatory research, knowledge translation, and active living and environments. Prior to Ireland, he has lived and worked in Australia, Canada, and Spain. So now I'm going to hand over to Professor Catherine Woods. Catherine.
Thank you, Ali, for that wonderful presentation. And also just to say thank you to Ali, who, where did that work? Can you see my screen, guys?
We can, yep.
Yeah. Can you see the full screen, or can you see the presenter notes?
We can see, I think, the full screen now, Catherine.
Yeah. Great. Okay, so yeah, just to say thank you for that lovely introduction, Ali, and also to thank Ali, who was a member of the research team and provided us with really excellent statistical advice in relation to the analysis of the Move for Life data. So, oh no, I'm right at the very beginning. No, sorry, I'm going to skip through these here. Sorry. This is my one here. Sorry, that's where I should have started. So myself and Enrique are going to talk to you a very quick recap on Move for Life, but we're going to look at some feasibility outcomes, process evaluation outcomes, evidence of promise in relation to Move for Life, and we have then some conclusions and take home messages. The Move for Life was an intervention that was designed with a peer mentoring component to augment existing physical activity programs. So we sought the best physical activity programs we could find in Ireland for the target age group. And we wanted to see if we could augment the reach of those programs in particular by using peer mentoring. And Move for Life is now reporting on a feasibility study, which included a pilot randomized control trial to evaluate the feasibility of the program, but also provide evidence of promise in relation to a definitive trial that could follow up. Move for Life works along the following concept, i.e. if we fund programs, we train sports development officers and tutors. If they can work with peer mentors, then the reach increases exponentially and it all feeds back up. So it's about a systemic change in how we provide programs. The research design was, as I mentioned, a pilot cluster randomized control trial. What does that mean? Effectively, what it is initially you go out into the community and you do your screening. So you run information evenings, you explain what the project's about, you explain the commitment to the participants, what will be asked of them, and you ask for their informed consent. At that stage, they give informed consent and they complete baseline measures. And then after that, we randomized not the participants, but we randomized the hubs, 8 sport and physical activity hubs across the counties of Limerick and Clare, mix of rural and urban communities, really targeting lower socioeconomic areas ideally. And we then randomized the hubs to either the Move for Life program or the usual care program or the control group, a waitlist control group who got the program once the study had finished. So that's what we mean by cluster randomized controls trial. We recruited 733 individuals. You've heard this statistic before during the week. 98% of them consented to take part, which we were surprised at. It was so high because people came to exercise and then we gave them a battery of questionnaires to fill in. But in actual fact, once we explained what the research was about, people were genuinely interested in finding out and getting involved. Most were female, 37% had at least 3 chronic conditions, and 41% were obese. So we were really targeting individuals who were inactive and over the age of 50. So looking at our feasibility outcomes, and feasibility means, can we run this again? Did we reach the right people? Was it acceptable to them, and so on? So the first thing that I want to show you is that we, out of the 733, we excluded 132. Now, from the previous slide, we had a target. We needed to get at least 576 people to make this a viable study. We exceeded that in that we recruited 733, but when we applied, you have to be inactive and over 50 criteria to our 733 participants, we lost 132. Why? Because they were too young. You can see here the included people were older than the excluded people. So people were excluded because they were too young or because they were too active. And again, you can see another interesting finding here. Self-report, there wasn't that much difference between the inactive, the included and excluded. But when we looked at it in accelerometer data, it was quite a drop, or quite a difference. So people were reporting that they thought they weren't as active, but in actual fact, when we measured it, the excluded individuals were quite a lot more active than our included individuals. Fidelity. This is to do with, did we deliver the program as it was intended, as it was designed? And according to the sports development officer tutor checklists, they said or indicated that they covered 508 of the 662 intervention components. Now that sounds like a massive ask, 662 intervention components over 12 weeks. But it was a 12-week program. The tutors were involved, the peer mentors were involved, and each week we had different things that we targeted with the participants. And Enrique and Amanda covered that in detail yesterday, so I'm not going to go into it again. We recruited 27 peer mentors and worked with them, exceeding our expectations as to the numbers that we would need and be able to recruit in the study. In terms of the attendance rate of participants at either the Move for Life or usual provision programs, what you can see here is the attendance, which was 64% for Move for Life and 59% on average for usual provision, and that was statistically significantly different, with Move for Life having a higher average attendance rate. And you can see it across the different programs between Move for Life and usual provision. And these are the programs down here at the bottom: Go for Life, Get Ireland, Walking Men on the Move, and so on. In terms of retention and data on completion rates, studied retention rate over the 6 months that we followed these individuals was 63%, and specifically 64% for Move for Life, slightly lower for usual provision, and interestingly higher for the control group. Now, this is not an unusual finding. It has been found in other studies. And we went back, we asked the control group, why did you stick with the study for 6 months, even though you weren't getting the program? And a key thing was that they were waiting to be offered the program. So that was really important to them. They said that they saw control as being an important part of the study design. However, they did think it negatively impacted on their community being in the control. So this is something that we would have to be aware of going forward with a definitive trial. Study dropouts tended to be younger, tended to be the less active individuals, and those who are more likely in work as opposed to being retired. Our data completion rates were very, very good. We had over 88% on either accelerometers, physical health, or psychosocial questionnaires, and all our study progression criteria were met. The process evaluation. So this is where we look at what the participants' experience was of the intervention. So first of all, was Move for Life acceptable to participants? And here you have, they were asked questions on a Likert scale, and what you have here is the percentage who agreed or strongly agreed. It was 4-point Likert scale, you can see it down there, with the statement. So what you can see here is that Move for Life found that the program was interesting, worth the time I invested in it. Our group in general enjoyed it, and I would recommend it to a friend. And these are significantly higher than the usual provision group. So there's something going on there in relation to acceptability. This finding here, we were interested in the assessment, the impact of assessing people at baseline, 3 and 6 months. And the question was the assessment, never mind the program, the assessment motivated me to keep active. And here you can see a significant difference in favor of usual provision. So Move for Life is doing something over and above only assessing the participants. There's something about this program that is making it interesting and worth the time people are investing in it. Behavior change techniques. We had a whole range. You heard a number of the components we had in the intervention. So we wanted to see whether participants perceived they used the behavioral change techniques. And what you can see here is that the Move for Life group at 3 months post-program enjoyed learning new strategies. They learned how to set personal goals and set a clear group goal. Now they were high in both groups, which is good, but they were significantly higher in the Move for Life group as compared to the usual provision group. And 3 months after they'd exited the group, the program, we looked again, and here what you can see is again differences between the group in terms of their personal benefits that they were reaping from physical activity, not necessarily the program, but physical activity in general, the understanding of personal barriers and how to cope with these and overcome them, and the group helping each other to remain active was higher in the Move for Life group in comparison to the usual provision group. In terms of social support and group dynamics, here at 3 months directly after the intervention, the Move for Life group indicated that they received support from other participants in relation to physical activity, and they were more likely to remain active after the program because of their group. And again, this is higher in Move for Life than usual provision. And 6 months from baseline or 3 months after the program finished, they reported they received support from more participants, they gave support to more participants, and they developed new friendships directly as a result of being involved in the Move for Life program. Autonomy, we asked them about the tutors. What was it about the tutors and how did they assess the tutors? And the Move for Life felt that the tutors provided them with more activity choices. The tutors offered a wide variety of activities to meet mixed ability, and they encouraged the group to be more active together after the program finished. And this was really what we were looking at here, was building autonomy within the group by the tutors, but also once the tutor would have left. And this is evidence of that. And finally, sustainability. We were interested in the impact that Move for Life would have on the local sports partnership networks. And what we found here, and in this slide, you're comparing 3 groups. You've got your Move for Life group, your usual provision group, and then your control group. And the question was in relation to whether they had become aware of their LSP physical activity opportunities. And the percentage that said they had become more aware was much higher in the Move for Life group than in the other 2 groups. They had contacted their LSPs for physical activity. They had registered for other programs, volunteered to help run physical activity programs, organized physical activity programs, attended PA in other venues, but not their hub, and met new people in their community. And the ones I want to draw your attention to here is they've become more aware, they contacted, they volunteered or organized activities, and they met other people in their local community. I'm going to hand you over now to Enrique.
Thank you, Catherine. And can you hear me well?
Yeah, we can hear you perfectly. Yeah.
Thank you indeed, Ali, for your advice and help with statistical analysis. Probably this is going to be a bit more technical than what you have heard now, but I'm going to try to make it in a way that hopefully is understandable to everyone. As Catherine mentioned, we were trying to test the feasibility of the Move for Life augmentation, behavioral augmentation, but also if it has any potential for impact on a number of selected outcomes. Catherine, if you can please move on here, the first one. So we have outcomes related to energy expenditure behaviors. I'll tell you a bit more about them later when actually I share the results with you. Body composition and physical function. I want to mention here, you see two of these outcomes, energy expenditure behavioral outcomes bolded. So average minutes of moderate to vigorous physical activity per day. This is accelerometer based, and self-reported physical compliance with physical activity guidelines. And these were our two main outcomes. Next, please, Catherine. We also have a number of outcomes that relate to mental health and to theory-based psychosocial determinants of physical activity that I will tell you also a bit more later for the sake of time. Next, please, a bit about the analytical approach that we follow to try to understand the potential for impact of the Move for Life augmentation. We used mixed effects regression models using a linear mixed model function in SPSS to first estimate adjusted differences in means between groups, and secondly, explore differences in rate of change between the groups. We used a consistent with the public health literature in this type of interventions. We used an intention to treat analysis principle. We use a strategy that takes advantage of all available data, and based on the methodological literature, we use a number of sequential steps, starting with testing, examining the distributional properties of outcome variables, and then we run a number of preliminary models to examine if the rate of change follows a linear or non-linear pattern, and then we tested a number of univariate predictor models to select the relevant and most relevant covariates for inclusion in the final models, and this was based on a ecological framework of physical activity and including LSP affiliation, and I'll tell you a bit later about the importance of this. And finally, we also conducted a number of sensitivity analyses per protocols. That is, we compared the main analysis with an analysis in which we analyze only participants that attended 70%, at least 70% of the sessions. And also you heard from Sarah O'Brien at the beginning about the importance of not only designing interventions, but implementing them. So we also did an analysis that accounted for the degree to which the Move for Life intervention was implemented as intended. And next, Catherine, please. In terms of the covariates that we tested in terms of accounting for potential confounders at the individual level, we accounted for age, gender, level of education, medical card as a proxy for socioeconomic status, marital status, body, BMI, a number of conditions that you heard from yesterday from Andrew. They're actually quite high in our sample. In terms of environmental factors that we controlled for in our analysis, in terms of actual environmental factors, urban versus rural location, area deprivation, and local sports partnership. One thing that is important for us to know here is that because of we didn't have enough accelerometers for all the participants, so therefore we have to stagger the intervention. So this means that the intervention was first delivered in Limerick, and more than 3 months after the intervention was delivered in Clare. So that means that this potentially may have introduced seasonal effects that we needed to account for. One thing I can tell you is that there were quite large differences in terms of physical activity levels. For example, between participants from Limerick LSP and the participants from Clare LSP. In terms of perceived environmental factors, we accounted for perceived access to public transport, perceived safety during the day and during the night, and also walkability of the area where participants were living. Next, please, Catherine. A number of strengths of approach. This is a recognized strategy for modeling change over time that it's what we were interested in. More specifically, this accommodates the hierarchical nature of longitudinal data, so observations grouped or clustered or nested within participants. This accounts also for variability and correlation introduced by repeated measures, which is very important when doing this type of longitudinal research. This also allowed us to to choose the best covariance structure for the nature of the data that we had. And finally, this is a suitable approach for handling missing data, which obviously, as you can imagine, there is a bit of it in pretty much in every longitudinal data set. And also it's a recognized good approach to deal with issues of unbalanced designs, for example, different numbers of participants in each of the treatment conditions, which was our case in our data set. Next, Catherine. Finally, I would like to suggest that this allows us to, indeed to account for the complexity in the data, to deal with that complexity in terms of analyzing change over time, examining both linear and non-linear effects, and including, as you heard before, covariates that represent multiple domains and levels of influence. Let's go to the results here in terms of just the differences in means in the two primary outcomes. So sensor-based moderate to vigorous physical activity and self-reported compliance with physical activity guidelines, sensor-based MVPA, moderate to vigorous physical activity. That's what this table, what you can see in this table, was consistently higher across time for participants in the Move for Life intervention group than for participants in usual provisions, and particularly control. As you can see there, compared to control, the difference at follow-up was estimated at almost at 6.6 minutes of daily MVPA in favor of the Move for Life group, and reached a statistical significance, as you can also see. And interestingly, this difference increased to almost 11 minutes a day in an analysis where we consider, as I mentioned before, implementation fidelity. I'll tell you a bit more about it, about the importance of considering implementation fidelity. In terms of self-reported compliance with physical activity guidelines, as you can see in the table, this compliance remained consistently higher reported compliance for Move for Life participants than for usual provision and control participants, and also for usual provision participants than for true controls. Remarkably, as you can see there at follow-up, 3-month follow-up after intervention, the percentage of participants that reported meeting physical activity guidelines was 14 and 25 times higher in Move for Life compared to usual provision and control, respectively. Next, Catherine, please. Differences in adjusted means only tell a part of the stories, as in terms of understanding the true effect of the intervention on the participants. It's important that we look at actual change over time, and this is what you can see in this table. Basically, this table shows the effects of intervention on what is referred to as the initial status, that is baseline differences between groups, and also is showing the group by time interaction. So because what we're trying to determine here is whether the effects of group membership or treatment allocation vary over time. And as I mentioned, the coefficient that you can see in the table show the differences, baseline differences, and also the group by time interactions. And you may be wondering about what is these quadratic terms here. They basically indicate whether the observed effects are proportional across time points or not. But for the sake of parsimony today, I'm not going to really spend much time on this today. As you can see in the table, there is a significant baseline difference of 5.6 minutes of daily MVPA favoring Move for Life over a usual provision. Over time, both the Move for Life and the usual groups appear to increase substantially their MVPA relative to control. You can see a 8.5 and 9.5 minutes a day, respectively, although neither difference is statistically significant at the specified level of P less than 0.05. As for meeting physical activity guidelines compared to usual provision and particularly control, the Move for Life intervention group underwent a large significant increase in the percentage of participants that reported meeting guidelines. And in addition, usual provision experienced also a large increase over time in the percentage of participants reporting that they met physical activity guidelines compared to control. Let me show you a bit of a graph here, because to better understand, thank you, Catherine, to better understand change and interactions, we plotted the adjusted means for each group over time, and the resulting trajectories, along with additional analysis stratified by group that we ran, revealed that while both Move for Life and Usual Provision experienced a small, not significant decline in sensor-based moderate to vigorous physical activity, the control group declined significantly over time. I don't know if you see it there, but the Move for Life is the blue line on top. Usual Provision is the green line. And thank you, Catherine. And the control is the red, is represented by the red line. So yeah, in terms then of self-report, so what we can conclude from this is that both Move for Life and Usual Provision had a protective effect regarding moderate to vigorous physical activity when compared to the decline pattern that we observed in for the control group. As for self-reported compliance with physical activity guidelines, that's the graph on your right. The trajectories in the graph illustrate a very large significant increase over time in the percentage of Move for Life participants that reported meeting the guidelines. They also show a large significant increase in the percentage of Usual Provision participants that reported meeting the guidelines, and a small, non-significant increase in the percentage of control participants that reported meeting the guidelines. Next slide, please. We can just skip this one, Catherine. We can just go to the graphs here. It's going to be probably a bit more easy for all of you to understand. So similar to sensor-based moderate to vigorous physical activity, sedentary time, that's the graph on the top left. Sedentary time remained stable over time in both Move for Life, that's actually the bottom line, the blue line over there, and Usual Provision, that's the green line on the top. Sedentary time was consistently lower for participants in the Move for Life group, but nevertheless, based on the trajectories of the means, we can conclude, similar to what I mentioned before for moderate to vigorous physical activity, here we can also conclude that both Move for Life and Usual Provision had a protective effect compared to the increase in sedentary time that we observed in the control group. As for the other secondary energy expenditure outcomes, the top right graph is about light intensity physical activity, which was consistently higher over time in Move for Life, while the trajectories did not differ significantly over time between the groups. You go to the bottom left and bottom right, time standing and number of steps per hour were consistently higher over time in Move for Life. But actually, to be fair with the with the Usual Provision group, the trajectories were slightly more favorable in Usual Provision compared to other groups, particularly regarding number of steps, and that's per hour, and that's the graph in the bottom right. Next slide, please. I think we can also skip this one. We're gonna go to, we can also skip this one. Let me go to show you the graph. In here, I'm showing you one of the body composition outcomes, specifically waist circumference, and the two physical function outcomes that we analyzed, specifically timed up and go test, which is a test of functional mobility, and the 6-minute walk test. You heard about this, about all these outcomes yesterday in García and Kira's presentation. The 6-minute walk test is meant to be a measure of walking endurance, but also mobility. So what these graphs show is that despite having significantly higher waist circumference values over time than participants in the other groups, so the Move for Life participants were actually heavier than participants in other groups, participants in Move for Life scored consistently and significantly lower, which indicates better performance in the timed up and go test, and completed more distance in the 6-minute walk test than participants in Usual Provision. The group trajectories suggest that waist circumference values, you can see that in the top graph, that waist circumference values decreased significantly in Move for Life relative to both Usual Provision and control. Consistently looking at the graphs on the bottom, trajectories show that the scores in the timed up and go test improved over time in Move for Life relative to usual provision, not control, but relative to usual provision. That's what you can see in the bottom left graph. And both participants in Move for Life and usual provision increased steadily the distance they cover in the 6-minute walk test relative to true controls. And you can see that in the bottom right graph. Next slide, please, Catherine. I'm just gonna finish my presentation giving you an overview of what we found in terms of the analysis of the psychosocial outcomes, as I mentioned earlier, outcomes that relate to mental health, but also to theory-based psychosocial determinants of physical activity. So variables that have been found in the literature to affect physical activity over time. And what I can tell in general is that despite a few unexpected findings, the overall pattern of results adds to the evidence of promise of Move for Life by illustrating its potential to impact positively the mental health of participants and again, change again these theory-based determinants of physical activity. Interestingly, the sensitivity analysis that accounted for implementation fidelity are particularly illustrative in this regard, and that's why I'm going to show you this analysis. Remember, these are analyses that account for the degree to which the tutors reported that they complied, that they implemented the Move for Life strategies that Catherine mentioned before and that Amanda and myself covered in some detail yesterday. So the degree to which they reported implementing those strategies as intended, and based on tertiles, basically we created a high fidelity Fidelity Move for Life group and a medium to low fidelity Move for Life group. As you can see in the table, somewhat unexpectedly at time 2, I'm only showing here for the sake of parsimony differences in adjusted means at time 2. So at time 2, the high fidelity Move for Life group was the only group whose ratings on well-being were significantly lower than those of the control group. As we will see though in the next slide, well-being scores among participants in this group were the only ones that actually increased significantly over time relative to participants in the control group. In addition, participants in the high fidelity Move for Life group reported significantly higher levels of relatedness to others in physical activity. That is the degree to which they feel meaningfully connected while doing the activities in their program. And so more related to others than participants in every other group, while both Move for Life subgroups, so high fidelity and medium to low fidelity, reported higher scores on subjective norms than controlled participants. And subjective norms refer to the perception that the people have about what do they think that others think, whether they think that others think that physical activity is something that they should be doing or not. Next, please, Catherine. In terms of change from time 0 to time 2, which is what you can see in this table, as mentioned in the previous slide, well-being scores among participants in the high fidelity Move for Life group were the only ones that increased significantly over time relative to control participants, while subjective norm scores decreased over time in usual provision relative to control, but not in Move for Life not in either of the Move for Life subgroups relative to control. Next slide, please. And in addition, compared to control, the high fidelity Move for Life group was the only group in which attitudes towards physical activity did not become significantly less favorable over time. And you may be wondering why did attitudes sort of decrease over time in most of the groups compared to control? As Catherine mentioned before, many people in the control group were really looking forward to actually start the program that they wanted to enroll in, and they were not able to enroll in. So they were sort of really eager, and that probably may have influenced this result. So as I was mentioned, so Move for Life was the only group in which these attitudes did not become significantly less favorable over time, and even actually improve significantly relative compared to the usual provision. This is not shown in the table because for the sake of parsimony, I'm only showing you comparisons between each group and control. Furthermore, compared to control, intention to participate in physical activity in the future decreased significantly in usual provision, but not in either of the Move for Life subgroups. And finally, I'm going to be finishing with this, my rather lengthy presentation on the outcomes. Finally, participants in the High Fidelity Move for Life group experienced a small but significant decrease in loneliness over time when compared to participants in the usual provision. And again, this is not shown here because for the sake of parsimony, I am only showing you comparisons between each group with control. A little conclusion before handing over to Catherine, and she'll expand upon these conclusions, and she will draw a number of lessons learned. To me, this is my personal interpretation of what I've just shared with all of you. The findings provide evidence of the goodness of existing LSP physical activity programs, particularly for energy expenditure related outcomes, and of the promise, that is the added value of the Move for Life augmentation intervention, and warrant a definitive trial to further examine the effectiveness of the Move for Life intervention. And having said this, I'm going to hand over to Catherine.
Thank you, Enrique. And I'm just going to very briefly summarize. Key findings were that fidelity was high, acceptability was good, retention was good. And as Enrique has provided you with, there was evidence of promise in relation to the physical health, functional health and psychosocial measures. There were some limitations in our study, particularly in relation to generalizability. Strengths were, it's a real world study. We carried it out in real settings. However, this may limit generalizability a little bit. We also need to work on recruiting more men, for example, the study period consisted of baseline 3 months and then 3 months follow-up, so 6 months in total, but really we want to do longer studies. So finally, just to say thank you to our sports development officers. You can see some of them here in the training, the peer mentors. Thank you also to all of our participants, without which this study would not have been possible. And you can see all of the different venues, including doing the 6-minute walk test outside because halls are not big enough, and doing them at different times in the day and the evening. And thank you to the research team, without whose help none of this would have been possible. And you can see there again, all of our different researchers involved at different stages of the project. I'm going to hand over to Paddy now, who's going to talk to you about the health economics analysis. So I just need to stop my share.
Yeah, thank you, Catherine and Enrique. That was very interesting. We're not taking questions at the moment, but we will obviously take questions after Paddy's talk. So I'm just going to very briefly introduce our third, basically, speaker of today, Professor Paddy Gillespie. Paddy is the head of economics at the J.E. Cairns School of Business and Economics. He is professor of health economics, director of the Health Economics and Policy Analysis Centre, and program director for the Master in Health Economics at NUI Galway. Paddy's research activity is focused on the application of techniques of economic evaluation, including trial-based and decision model-based analysis and econometrics to inform health policy and healthcare practice. The output from this work, which has involved collaboration with colleagues across multiple disciplines, has been published in a range of leading national and international peer-reviewed journals. So I'm going to hand over to Paddy. Paddy.
Thank you, Ali, and thanks to Catherine and Enrique. Hopefully you can all see my slides and hear me okay.
Yeah, perfect.
Okay, great. So my role as the health economist is to present the health economic analysis, and it very much piggybacks on the work that Catherine and Enrique have just presented. And my kind of remit today is to, I suppose, introduce the framework we use to assess cost effectiveness, to assess value, because this is the technique we apply to evaluate the cost effectiveness, or I should say the potential cost effectiveness, or the evidence of promise with respect to the value or cost effectiveness of the programs that were involved and evaluated in the Move for Life program. So to give you a sense of our aim is, I suppose, because it's a feasibility study, we want to assess the feasibility of, I suppose, the methods we've designed and employed to evaluate these interventions. In addition to that, we want to look at the data we have generated through the study to assess, at this preliminary stage, the relative cost effectiveness of these strategies. So if I point over just to the right-hand side, just to give you, those of you that may not have experience in the methodology, to assess cost effectiveness, essentially you need 2 or more comparators because you have to be cost effective relative to something else. And also you need 2 variables or data on 2 types of variables. One are the costs associated with both the delivery of a particular healthcare intervention or technology, but also we need to get a sense of the impact of that intervention on other healthcare services that individuals might use. So nothing happens in a vacuum. The very fact that I engage in a certain treatment alternative may impact upon my use of other services. There may be side effects that result in higher costs, or my health may improve and I may not require those healthcare services. So we want to capture as much of those costs as we can. On the other side, we're interested on the consequences of treatment, and predominantly we focus on the health outcomes. And Enrique presented a whole range of health outcomes in his previous slides, which give you a sense of the impact of Move for Life and usual provision and the control arm on health outcomes for those that engaged in the study. So in this particular case, the comparisons we're going to make is we're going to compare the Move for Life intervention versus usual provision, those physical activity programs we're all aware of. We're going to look at Move for Life versus the control, so no organized programs of physical activity there. And we're going to look at usual provision versus control, so those standard LSP physical activity programs, how did they compare relative to the control of essentially no organized physical activity programs. Now, importantly, we're going to look at both costs and outcomes. And on the cost side, we're going to look at general healthcare service usage. So primary care, community care, hospital care services that individuals use. We're going to collect data on those and cost those up. We're also going to look at the Move for Life intervention itself, that peer mentorship model that was kind of implemented in addition to the physical activity programs. We're going to cost that up. And then we've got the physical activity programs themselves. So again, engaging with the study team, we've come up with estimates of the cost associated with delivering those programs. So all those together will form the cost component of our analysis. On the other side, in addition to the outcomes that were presented in the previous slides, the key outcome in health economic evaluation is called the quality adjusted life year. And if you look at my bottom right-hand slide here, this gives you a sense of what a quality adjusted life year is. And in theory, it's a very compelling health outcome in the sense that it attempts to simultaneously capture impacts on quality of life and length of life in a single outcome measure. And then it's a generic outcome measure that allows you to compare across different treatment alternatives, both within kind of a narrow focus of a program like this. How does MFL, intervention, usual provision, and control impact upon qualities? But also, if you wanted to, you can compare these programs to programs outside of this particular study, and you can evaluate the cost effectiveness of these strategies relative to other things you could do with limited healthcare resources. So we're going to use the EQ5D5L instrument, which is a questionnaire essentially that focuses on 5 dimensions of health status. So you've got pain and discomfort, you've got the ability to engage in usual activities, you've got mobility, you have anxiety and depression, and the ability to engage in self-care. So there's a questionnaire, we take that data, and that's the quality of life piece. In terms of the quantity of life piece, or the length, the quantity component goes into our quality, we're limited to the time horizon of the trial, which is 6 months. And up front, as Catherine said in the previous slide, this is a limitation of our work in the sense that if you imagine the impact of these types of physical activity interventions, you'd imagine you've got short-term interventions that have long-term implications, and those implications you would imagine would last beyond the 6 months for which we collect data on. So that's a limitation that you would like to build upon and improve upon in future studies with a longer time horizon to capture the wider costs and impacts. So In terms of how then we define cost effectiveness, what we're going to do in this slide here on the right hand side, I'm calling it the cost effectiveness plane. To make these comparisons, we're going to lump one comparator at the origin, and if you fall above this axis here, this x-axis, the strategy is more costly than your comparator. If it falls below, it's less costly overall. And if we look at our y-axis here, the control again is at the origin. To the right, you're more effective in terms of qualities, and to the left, you're less effective in the sense that you disimprove health relative to the alternative. So we're going to look at where we find and where we fall. And, you know, if you were an intervention that saved money and improved health, you'd be cost effective in the sense that that's a win-win scenario. If you had an intervention that was more costly and less effective in terms of health outcomes, well, you're not cost effective. Up in quadrant 3 here is where our analysis is going to fall. And if you think of new drugs and new devices and most new health technologies, generally they would be more expensive than routine therapy, and they would be more effective. And the question up here then is, are you willing to pay the additional cost to get additional health outcomes? And those are very challenging questions. So to answer those questions, you need down the bottom here a statistic called the ICER, the incremental cost effectiveness ratio, which simply is estimated by dividing the difference in cost by the difference in outcome. And what that tells us is essentially how much you would have to pay to generate one additional quality. And this is the standard approach with this methodology to identify essentially whether something would be deemed cost effective or not. So your ICER is compared to a maximum value or a threshold value that a health system is willing to pay to generate one additional unit of health. And in Ireland, if you look at guidelines from the Health Information and Quality Authority, who essentially produce the guidelines for the conduct of health economic evaluation in Ireland, numbers in the region of 20,000 to 45,000 euro per quality are being presented and mooted as our kind of maximum value that we would deem to be cost effective. So this is the framework we're going to employ to assess the cost effectiveness of these three strategies relative to each other. So let's just move on then. So if I can, here we go. So here's the raw data, if you like. And remember, I mentioned, if you look at the variables on the left-hand side, we collected a whole range of data on healthcare usage. And again, we've got GP visits, practice nurse visits, outpatient, inpatient admissions, A&E visits. Now, in terms of this kind of preliminary analysis, it is limited. You can imagine a whole range of other services you could add in there. Again, that's a limitation of our work that we'd like to expand upon in the future. If you look then at the second component of cost, we've got the Move for Life intervention, the peer mentorship model, implementing that cost on average about €37 per patient. And then we have the cost of all the physical activity programs. We essentially lump them all together and evaluate them together. And you can see overall for the Move for Life intervention, the kind of shaded area here, on average, the cost was €354.71 per individual that participated in this program, compared to usual provision, which didn't have the Move for Life piece. It was $233.39 per patient on average, and the control group, who obviously didn't get any physical activity program, but they did engage in and use other healthcare services. On average, they consumed €155 at 38 euros of costs. So that's on the cost side that we're going to compare. On the outcome side, these quality adjusted life years, and remember the follow-up period here is 6 months, it's half a year. So the maximum you could earn, if you like, in a given year would be 0.5 qualities. And you can see here on the basis of our returns at 6 months, 0.456, 0.445, and 0.451 for each of our comparators. And these are our comparisons. So not everybody's in perfect health. If you're in perfect health, your quality of life would be 1. And a quality would equal, our quality gain would be 0.5. But the quality of life impacts in this cohort of individuals who are older they're not in perfect health, and that makes sense in the context of the study. So let's bring it all together, and here's our cost effectiveness plane, and I'm just going to go through the analysis for each of our 3 comparisons. So if we start off here with the Move for Life intervention relative to usual provision, you can see if we put usual provision at the origin, we see here that the Move for Life intervention is both more costly and it's more effective on average. So on average, it costs 120 euro more per patient, and on average, the gain in terms of qualities was 0.002, which is a marginal gain. But again, it's a short period of time, it's only 6 months. So if I calculate my ICER here, which is 120 divided by the 0.002, we come up with an ICER of 54,959 euro per quality. So what that tells us is we'd have to pay that amount to generate one additional quality. And if we compare that to the threshold value that's mooted in Ireland for about 45,000, Move for Life relative to usual provision would unlikely to be deemed cost effective. And here's our uncertainty analysis. We present this using probabilistic methods, and essentially would say at this threshold value, there's about a 47% probability that this intervention would be deemed cost effective. But importantly, remember those limitations. Remember the time horizon of our analysis is limited to that 6 months. And if we expanded that follow-up to beyond 6 months, potentially we would see those benefits down the line. Let's now look at Move for Life versus control. And in this case, you can see that the results are slightly different. Our ICER, again, we're more costly, we're more effective. The ICER is below 45,000 euro. And in this case, given the evidence we have, there's about a 54% probability that we're cost effective. And where these probabilities and probabilistic results come from is the evidence we have from our feasibility study. Again, going back to Enrique's point, a definitive study would give us more power and more data to work with, and potentially lead to higher probability values here. And our final comparison is comparing usual provision. I suppose those physical activity programs that we have used within the study, and we compare that to the control, no organized physical activity programs. And here, I suppose, is the most positive findings, in the sense that, you know, again, you're more costly on average and more effective in terms of qualities. Your ICER is very acceptable, 21,672 euro per quality. And in terms of the weight of evidence we have from our study in favor of the usual provision relative to control, it's about 0.668. So almost, 67% probability that the usual provision is more effective and cost effective than control. So again, bringing it all together in summary, we found that the methodology, I suppose, we designed and implemented here was feasible, it was acceptable. There are tweaks we'd like to make with respect to including more cost elements, but also maybe expanding upon the time horizon of the analysis so we can capture those longer term impacts. Our preliminary findings, again, real evidence of promise, the potential cost effectiveness of Move for Life, and particularly usual provision relative to the control of no organized program at the 6 month follow-up period. And again, going back to that, putting the researcher cap back on, I think there's real value in going back into the field and having more comprehensive study design for our health economic evaluation with extended follow-up periods. I think that would be hugely valuable to build the evidence base and provide more definitive findings. So that draws to conclusion my presentation, and I think I hand back now to Catherine and the team, and happy to answer any questions that you might have.
Hi, Paddy. It's actually back to me this time.
Sorry.
No worries. You couldn't know. I think Ali had to pop off, so I'm going to take over. My name is Benny Cullen. I'm Director of Research and Innovation in Sport Ireland. I'll be chairing the next session, but I might pop in here just at the tail end of this session to capture a few questions. Firstly, thanks a lot to Paddy, Catherine and Enrique for some complex analysis there. If anything, it shows the complexity of trying to find, where these solutions really lie, and trying to really uncover what works and doesn't work. I have a couple of questions that actually came in on the chat. I might start with possibly a question for Catherine and Enrique. Enrique, you mentioned sometimes you have some missing data within the study. Is there anything you do in order to try and compensate for that? And is there anything we can do in future studies to reduce the amount of missing data that is submitted?
Yeah, as I mentioned earlier, missing data is a part of doing longitudinal research. It's a challenge that everyone doing analysis, longitudinal research has to face. There are different approaches to deal with missing data, anything from removing participants for whom data is missing, to up to doing some form of multiple imputation, to something like we did that has good support in the literature, which is some form of system-based imputation, which is called maximum likelihood, which again, we have pretty good support in the literature for using this, because we thought, we worked so hard to recruit participants, and again, there's some debate about it in the literature, but there doesn't seem to be a good option just to remove participants just because they are missing one data point, when there are good ways of actually accounting for that, modeling that missing data with sort of modeling statistical techniques. So that's the option that we follow. As to how to reduce sort of missing data, well, basically I think is Catherine mentioned yesterday, Andrew mentioned about the strategies for increasing recruitment. Catherine mentioned today about actually participant retention. Obviously we have some issues, but what's pretty good in Move for Life. So I think in the end is just to be able to deliver a good program as possible, so participants want to keep attending the program, and also making sure that people understand the importance of the assessment sessions and making them useful and enjoyable as much as possible for the participants.
That's great. Thank you very much, Enrique. Paddy, I have a question in for you. People asking if you can measure social impact beyond the health impact in health economics analysis.
It's a really good question, and it's really topical in the health economic evaluation literature. As you'll see, our focus was on a kind of a clear health outcome, and if you think of, I suppose in course terms, you're trying to maximize this health outcome given the limited resources you have. But you could make legitimate arguments that health isn't the sole outcome measure of interest. Certainly in the context of these types of interventions, whereby benefits aren't purely on the health side, and maybe beyond that. And I think it reflects, interestingly, where these types of methods originated and where they were applied initially was very much in the space of pharmaceuticals, evaluating new drugs and new technologies where health would be the impact. So you can, like, the simple answer is you can capture those other types of outcomes if you wish. And if you can measure them, you can include them, but it's difficult then to judge cost effectiveness beyond the simple comparison that you have. So for example, we could have social outcomes for Move for Life versus usual provision, see if Move for Life is more cost effective at achieving that outcome relative to usual provision, but then to make the comparison beyond that to other ways we could spend the money and those limited healthcare resources in the context of, diabetes care or cancer care, that direct comparison can't be made. So generally what you do in practice is that you would do both. If you have the data, you would present the results focusing on that quality measure, the health outcome measure, and then supplemental to that, you would capture those other aspects and those other data. So some of the findings that Enrique presented, you could do a cost effectiveness analysis focusing on, waste tip ratios or some other measure, or you could look at some of those psychosocial measures as well. So in theory, it's possible, but what it does then, it limits the findings or the discussion points you can generate relative to other resource allocation. But it's a really challenging, and I think it's a valid point.
Thank you very much, Paddy. Catherine, I'm going to ask one question to you, and then I'm conscious of time, so we'll move on then. There's some other great questions here, so hopefully people will get in touch with you individually after that. Just a question about, so this is from Seamus Hogan, question about the information between usual provision and MFL groups. The slide said that the usual provision group perceived that assessments motivated me to make change was higher for usual provision than for MFL. Why do you think that would be, and what was the main difference in the assessments, or was there a difference in the assessments?
Yeah, no, a great question, and an unusual. We weren't expecting that finding, but one thing that came up when we were doing the baseline assessments, there was a lot of participant questions around why are we doing this test. So it was almost like an educational intervention on its own in relation to their own health. Now, we didn't provide results to the participants until the end of the study. We were precluded from that in case it influenced their outcome. However, we did ask a question in the process evaluation about the assessment. You know, was the assessment the right length? Was it too long? Were the questionnaires too difficult? We asked those sorts of questions. And one of the findings that I presented there was that a lot of them said that alone motivated me to stay with the program. So the learning from this is that for some participants, that number wasn't as high as the actual program outcomes, but for some participants, actually running regular, systematic, field-based assessments of the nature that we used in Move for Life could be an effective intervention for people to remain and stay active in whatever way they then choose to go out and do that.
That's really interesting, Catherine. I think certainly an interesting point for us to consider, maybe even start testing in field in other programs. Okay, I'm conscious of time, so there's loads more questions there. Hopefully, you never know, maybe at the end we might get a chance to come back to some of them. But I'm going to move on to the next presentation, if that's okay. It's my pleasure to introduce two of my colleagues, the Phelim Mackin and John Sweeney. They are the coordinators of Limerick and Clare Sports Partnerships. Two dedicated, driven, inspiring individuals. They've been involved in sports development for over 20 years, and they have a shared passion for getting people of all ages, all backgrounds, all abilities, active in their local communities, so that we can all reap the benefits of being, physically active and taking part in sport when we can. So John and Phelim are going to bring you through, I guess, the real-world experiences of bringing research to life in the field. The presentation is going to explain how they took Move for Life and integrated it into some of the local sports partnership programs, and give you a bit more insight on some of the impact it had on participants, and especially the impact that it had on practitioners, their own colleagues within their sports partnership. So I'm going to hand over to Phelim and John now, and really looking forward to the presentation. Thanks a lot, guys.
Thank you, Benny. Very kind introduction there, and it's a great opportunity to have the opportunity from the LSP perspective, from both myself and John and Limerick and Clare, to, I suppose, give our side of the story from that whole journey that has unfolded over the last 3 days, from the findings and the results and the impacts. And I think it's important from a sports partnership perspective to look at the why, in relation to the value of this kind of work, and how it can add a lot of value to what we're doing in relation to our role as organizations. So we were fortunate, primarily as well geographically, in relation to our access to the University of Limerick, and that department in relation to engaging research and how we look at that across multiple target groups. So this is something that is ideal for us, because we have a lot of partnerships running in various departments within the University of Limerick, be it in the physical education and sports science department, or it is in the physio department. And then across the other institutions, we would have opportunities to engage through the medium of the community coaching in LIT, and again with the primary school teachers in Mary I. So again, it's about how can we be more informed in relation to the target groups that we are looking to support through our various interventions and education programs. So effectively what myself and John are going to do here over the next 20-25 minutes is kind of highlighted from a number of perspectives. We're going to look at it in relation to the LSP in general, and that overall knowledge and understanding piece. We're going to look at it from how this study has impacted on our SDOs and our team of sports development officers that work on the ground, and then crucially the team of tutors and support practitioners that help in the delivery a lot of the programs and interventions that we have. And then when we hand over to John, he's going to look at it from the perspective of the role that the peer mentor plays in the work that we as LSPs deliver in our communities across the country. And then even taking it a little bit further, looking at how in some of our more new developments within the sports partnership offering around our community sports hubs, how this actually really enhances and slots into that. So if we think again of, why did we get involved in this kind of partnership? I think if we look at even the simple role of the sports partnership and its three key functions, research is jumping out there in the first one around that information piece. Education was central to a lot of the outcomes of the study, both from the peer mentors perspective, the participants perspective, and crucially then to us as a team within the sports partnership. So there was a lot of education, a lot of resources that were developed that are now being used in a lot of our programs. And then crucially, the final one then around implementation, it's around that program delivery and what can we do to have greater impacts with our programs? What can we do to have greater sustainability in relation to the types of programs, et cetera, that we offer? And this Move for Life research really facilitated that, because there was a lot of departments. We have heard from all the different components through the various speakers over the last 3 days. And even when you're looking at some of the key findings in Enrique's presentation, it gives you that real encouragement to stay involved in this kind of research, because that's massive ammunition when you're providing participants, especially those targeted communities, with that kind of added value in relation to the benefits of. So that's always been really crucial for us. And when we look at it in this guise here, that again, at the end of the day, participation is what the key outcome is. So the more we can multiply the base in relation to people engaging in physical activity, looking at lifelong involvement in sport and physical activity, then the methods to do that is going to be very important for us, how we can sustain that and how we can grow that. And we have various models that we have used ourselves down through the years, backed up by other research across other types of programs. For example, we have a lot of research done around men on the move, historically ourselves linked with both masters and PhD students in UL, looking at teenage girls' engagement in physical activity, women from disadvantaged communities' engagement in physical activity. And then now this was another fantastic opportunity to look at that with our older adult target groups. So again, it's about that informed piece. It's about how can we grow and maximize, and then obviously crucially to look at that sustainability piece. So for us, partnership is crucial to everything we do. We don't operate in a silo perspective in any of our communities. So that huge relationship piece with the likes of the third level institutions that exist, and then obviously the students, both postgraduate and undergraduate students within those, and how they can really help us in delivering a lot of the initiatives, etc., that we're trying to develop on a weekly basis. For us, again, it's that huge piece around evidence and validation. It's about, are we testing a lot of what we are delivering on? And that's crucial. We, as sports partnerships over the last few years, are now using the SEM program, the single item measure, to again look at from a self-reporting perspective to see what works with whom and under what conditions. But this study, this Move for Life study, absolutely gave us real clear evidence in that. And there was elements of self-reporting in it, but as García highlighted earlier in the week around the use of the accelerometers and all of that and collecting that data, again, it was very clear evidence of what actually does work and what were the key successes and outcomes. And for us, that's again around needs analysis. It's getting us to be very aware and informed around our target groups. And it goes a long way in helping in funding applications, in that you have very clear evidence around particular target groups, around particular initiatives and the success that they can have. And that's another key element, that previous experiences and successes around research had us absolutely not hesitating when we were approached by Catherine and her team to see how we can develop this program. Crucially as well, when we look at the physical activity guidelines and we look at the physical activity outputs across our target groups. So if we look at from the 45 upwards age group, you know, the percentages are low and decreasing as we get to the 75 plus. So again, we have a responsibility in making sure that we are informed as to how best get more people in these age groups physically active. And then thankfully, we have a national sports policy as well, which helps support us in doing that. Research is a key element of that. Community is a key element of that. And then looking at those prioritized target groups and how we can support them. And again, it comes back to that evidence and being informed. And I think one of the funny kind of stories we have around talking about particular programs and supporting the sports partnerships was when Leo Varadkar was the Minister for Health for, albeit only a small duration. One of the things that he did highlight in some of the discussions and meetings that he had with the LSP networks at the time was having clear evidence of what works. When there's clear evidence of what works, then it will be supported financially, and that funding was crucial to this. So this is another huge kind of justifiable reason why it's important for LSPs and other organizations to link with the universities where possible to carry out this kind of research. Looking at it in relation to the Move for Life model. So we are looking in this study from an LSP perspective of our traditional delivery models. Well, so we were the usual care, and then seeing how the Move for Life model will have a different impact. If it has a greater, I suppose, impact around sustainability, has it increased the greater successes around some of the baseline measurements that we're taking, and then crucially, how many of the participants are still involved in different interventions that the LSPs are now involved in. So for us, there was a massive amount of positives and successes that was going to happen from this study. Crucially, there was going to be an increased level of understanding and CPD for our tutors. There will be some new ideas for our sports development officers in relation to identifying tutors to support programs and identifying the needs of the target groups that the tutors are going to be engaging with. The role of peer mentors is a key area of the work of the sports partnerships, and John's going to deal with that in a little bit more detail further on. But peer mentors are key to us in relation to how we support our programs. The participants, thankfully, when we've seen a lot of the evidence, there was a lot of positives for the participants in their own health, their own well-being, their own understanding of the benefits of physical activity to their overall health and well-being. And then crucially for the communities, having the 8 hubs was very important, some of which were in identified areas of community sports hubs, but others weren't. It was again identifying a community that had a central point of a facility and then seeing how we could build from there. And I think the figures, you know, looking at 733 participants putting their hand up to come and participate in a program like this is also showing the huge evidence around the appetite that's out there for people to be more informed and to be aware. And having been at a lot of the registration nights, it was great to see the different dynamics in relation to the characteristics of people that presented, and particularly to the much maligned males that are in a very small percentage in relation to the studies here. But I remember where you're trying to see what motivates people to come. But I remember being in one of the facilities one night and it was getting, I think, to close to 11 o'clock, and we had nearly packed away most of the requirements that we had there for the testing. But we identified a gentleman that seemed to be hovering outside one of the community centers. And again, he had got as far as there, but he just hadn't got in the door yet. And he was kind of observing to see what was going on. But he was also making sure that he was coming when there was hopefully not many people still at the registration center. But he eventually came in and participated, and crucially is still involved. So for me, that's a person that, you know, the environment was there. It was an element of hesitancy around it, but the confidence and the motivation to ensure that he did take that step was strong enough for him to actually come in that door eventually, provided that there wasn't a lot of people that may or may not know him in the room. So I think the men, and it has come up a few times in the different presentations over the last 2 days, we got to still do a little bit more work on how do we attract those men. And I think it was really highlighted around, if you had longer time in the recruitment, where you really target those men's groups and really inform them in relation to what the outcome was going to be and what you'd hope for them to experience during that journey. So I think that future planning and program delivery piece is really endorsed by a lot of the findings that were found in a lot of the work that we did during this study. So obviously we're looking at the traditional model. So Enrique has highlighted that. So we have our tutors that go in after our sports development officers identify a target group or a community. And then, you know, in some cases we have community champions, in others we have walking leaders, etc. But this was the traditional model. Where the real learnings and the real benefits for us as an LSP in this study was in relation to what they learned, what our tutors learned, what our sports development officers learned when they were looking at it from that Move for Life piece. So those additional pieces. But like our traditional models have served us well. You know, we have evidence around our Men on the Move program and that huge research on the key role that a tutor facilitator plays in the success of the program. It's about that ability to connect and engage with the participants. And in some areas, it was really about that banter almost, where it was going back to the days of their participation in sports teams, etc. So that environment needed to be created, even though they were now in their 40s, 60s, 70s, etc. So that model, we've had a good understanding of it. The next model then, which was the Move for Life, allowed us to really explore that there is different ways of delivering, that we can have a better understanding of that social connectedness piece, which is as important as the physical activity piece. But crucially then as well is how do we connect with the participants? So that relationship piece, going back again to the type of tutor that was required in relation to the Men on the Move type program to ensure that there was a successful outcome and that men looked forward to coming back each week. The behavior change strategy was probably a new one for some of our tutors based in the fact that they come from different backgrounds. We would have personal trainers, we would have physical education teachers, we would have sports scientists, etc. that would have been around a lot of our programs and are supporting those on a daily and weekly basis. So again, getting a better understanding of their behavior change strategies. And do they have that? How do they facilitate feedback and feed forward in the session? So some of my tutors really commented on that part of the learning with the Move for Life practitioners, that was an important part of their own development and how they do that. And then crucially, how do I involve the participants more in their own learning and development? So there was things like getting them to do homework, you know, and getting them to have identified one or two things around their goals by the time they came back to the next session. So that was that ongoing piece and that self-directing, and then that also motivating and encouraged them to look at that. So for us, our tutors really found this CPD piece very beneficial. There was a lot of learnings in it. It actually allowed them to reflect somewhat on how they were actually delivering. And when we look at some of the tutors that we had in there, some of them were working in childcare settings, schools, office type jobs, but they were some of our cycling instructors who were trained as road captains and road leaders. they weren't involved in the day-to-day physical activity role. So it was interesting to understand their dynamic and their understanding of how you engage participants on a program and the success of that in those people coming back. But the beauty of a lot of our road leaders, they were previous participants on a program. So their original engagement with us was that they were a participant. So they're almost like our ultimate peer mentor that had previously been a participant on the program, but are now in as the road captains and the champion to keep those groups cycling each week. So they found, I think, the greatest impact of that journey where they were trained as Move for Life facilitators. So a lot of the key outcomes for them, based on the feedback, was that opportunity for setting goals, both for themselves and for the group. I think a simple term and phrase that Nolik had used with them was around planning the work and work to plan, and being very familiar with the needs of your group and how you can achieve what you want to achieve, both individually, but also collectively. And then looking at different behavior change strategies and how they might encourage those to occur in the environment that they were working in. And that exercise buddy was one of the ones that definitely was probably the strongest around our walking groups, where they really seen the value of when they were not coming into our collective sessions for their physical activity, that they had an arrangement with somebody else that they would meet the other days. And that was a crucial thing that has come out quite strongly in relation to the Move for Life piece. And then finally, reflections, looking at, do we reflect enough on our activity? Do we reflect in advance of our next sessions? And is there any changes that we do because of those reflections? So for us, this piece was also crucial, where prior to the tutors and SDOs participating in the Move for Life training as a tutor, they had looked at their initial understanding of the various areas around their confidence, and looking at that feedback, then having completed the study, it was great to see I suppose a stronger confidence in our tutors and our SDOs in relation to all of the process evaluations that the lads have here on the left that Enrique and them would have gone through, which is around the feedback, those social support strategies, managing group dynamics and understanding that piece, and that intrinsic motivation for the individual. So they were looking at, those prompts. And for us, the communication styles is crucial a lot across a lot of our target groups. We go back to, I do anyway, crucially in relation to Lee Moggan, who was one of the key coach educators in Sport Ireland coaching down through the years. And he always talks about, if you want to coach anybody a sport, you need to know the sport, but you need to know the person, and that they're so connected that the better that understanding you have, the more success you will have. And then crucially, the sustainability piece. It's the ultimate in the success of any program or initiatives that the LSPs are engaged in, is what is the sustainability of it. So for us as an LSP, as an organization, that huge development for our staff and our tutors, and then ultimately our communities and target groups, was a massive learning and a massive benefit. So I'm going to hand you over now to John, who's going to move into the peer mentor piece. But just before I do, these resources that the lads developed through the Move for Life piece are excellent documents that we now have as documents that our tutors and new tutors can look at, depending on the background that they've come from in relation to being a tutor on an LSP program. So we now have a resource that is crucial to supporting our tutors on the ground, and even using it as well for some of our youth leaders that come through our VIP youth leadership program and our new peer mentors. So again, it's an additional resource in relation to helping them have a better connection with the groups that they work with. So thank you for listening. And again, crucially, thank you to my staff and all of the sports development officers and tutors that are within our organization that participated in the program. And then crucially to all of the participants themselves. we thought it was a big ask initially around the numbers, but then when you see the level of interest and the appetite for it, that we actually had more numbers than we actually needed. And I love that stat that Enrique highlighted earlier on, where we had to exclude 132 because they were already at a high level of physical activity, or they were younger. Not so sure about the younger bit, but we'll go with they were more physically active. So it was nice to know that there was a good cohort of people that were meeting the requirements. So I'm just going to hand over to John. So thank you for listening.
We're having difficulty hearing you there, John. I'm not sure if you can check your mic.
How's that? Testing.
That's spot on. Thanks.
Okay, I said to Kira earlier on that might happen because my computer does this for some reason. When I come off mute, it takes me off the system. So I was saying thanks a million, Phelim, and thanks to everybody for joining us this afternoon. I'm very conscious of time. We need to be finished by 2. Everybody's been sitting for the last 2 hours, or maybe you're standing. We can't see each other. So I'll just get straight into it, and I won't give you death by PowerPoint. So Phelim, if you want to move on one slide, please. So the peer mentor training and the peer mentor element of the Move for Life program has been is crucial. Phelim, can you move on a slide, please? Okay, thank you. Has been a crucial element of this of the program, and it's crucial, as Phelim mentioned earlier, it's a crucial element to the work that we do within the local sports partnership. And we've learned this over the years. In the traditional model, as Phelim mentioned, was that very much a tutor would go in and would try and get a community or a target group of individuals active in their own setting. We've learned over the years that this just doesn't work sometimes. Sometimes you'll hit on a jackpot, yes, it will work, but other times it won't work, especially when you're with a target group of maybe minority groups or older adults, and a group that needs to gain your trust. So what a number of us have been doing over the years is working with a peer mentor concept, and what the Move for Life project has done is it has really enhanced that peer mentor program for us. And what the peer mentor really is, it's a local and it's a trusted person that we can work with within a community to actually work with their own peers to get physically active. We already do this in some settings, as mentioned, like walking leader programs, Fit for Life leaders, PALs, Go for Life leaders, road leaders for cycling, and in park runs are volunteers. These are people that can champion sport and physical activity within their own peer network. Within the older adult population, this is even more important because this peer mentor will be a real key enable for us to understand and who are the people that we need to target, who do we need to talk to, and also where the facilities are and what these people would need within the facilities. And this is where the sustainability comes in. Liam Glynn mentioned earlier on in the week about where maybe the genesis of the Move for Life came from, when a piece of research that Liam, myself, and others were involved in developing an older adults program. And one of the key findings, and it's brought through in this as well, one of the key findings was even just that social connectiveness. Sometimes the physical activity may not be the important thing. It may be a byproduct of getting the older adults together. And to keep that social connectiveness, we need to have things like the cup of tea and the scone, or the time to chat afterwards, or the warm location. And also the very important piece is where the tutor is actually somebody who is a warm person and can connect with the people. You move on there, Phelim, please. So what would who are the mentors, what were the mentors expected to do? First of all, I think you should go back, and things on the next slides, how the mentors are selected, or who are the peer mentors. So we've already said these are people within the communities that have a connectedness within the community that we have identified, or our tutors may have identified, or may have come forward to us that they want to get a program going in their communities. At the beginning of the program, these people will be identified, and they'll be kind of a trainee mentor, if you like. But then a 3-hour program was developed to train these people to work with the resources like Phelim showed, and to give them some more support, like how to access funding, how to access facility, and all those kind of things. So this is what the real peer mentor was built to do. So build rapport by providing encouragement and support to Move for Life participants, assisting the tutors, setting good examples. So they're the ones that's really going to be the champions in their area, and helping the hub to sustain beyond the Move for Life program. within their resources, like our tutors or like our own professional development and continuing professional development, they were asked to reflect on how they're interacting each week and how the program went. And then they would report back to the research team as the voice of the participant, of the mentor participant as well, which is very, very important. Move on there, Phelim. So this is kind of the model of what the peer mentor program looks like. So the little green figurine is the tutor. The blue figurines are the people who have been identified, who have come forward as potential peer mentors. The red figurines are when they get trained as peer mentors or when they engage in the program. So not to labor on the diagram, but as the program progresses from week 1 to week 12, 13, the idea is that we would train, say, the first 2 people within a group. We would train these people to become peer mentors, but then they in turn, through their interactions with their peers as their mentor, maybe they might interact and engage other people. So they in turn, we can identify maybe another 1 person each. So suddenly we've trained another 2 people. So that becomes 4, 4 might become 6, 6 might become 12. So it's like a cascade type model of trying to encourage these people that we have identified, or people who have come forward, in order to be champions in the community. For a local sports partnership, this has really enhanced the way Phelim and I in Limerick have been working with our peer mentors, because it's given us a structured program and something really structured that we can go back to these people with these mentors and provide this training to. And in the future, now we've had difficulties obviously with COVID to continue this, but it will be something that we'll be following from now and into the new year, is that it is very important that it gives us a structured way to approach that. So the participants in there, the peer mentors who are the participants, how has it helped them? So what we have found, it's like any of us, if we understand why we are doing something, as Phelim said, know your sport, know your people. If we understand why we're doing something, so if these older adults can understand why it's important to be physically active, how does a program work, as in, what are the important elements, like a warm hall, a good tutor, a cup of tea, or whatever it is, we can build sustainable programs into the future. We spoke about, Phelim mentioned sports hubs earlier on. They're building into our Move for Life hubs. So some of the Move for Life hubs are based within our community sports hubs. And for those of you that don't know what they are, they're hubs of sport and physical activity that we have developed with the support of Sport Ireland and Dormant Accounts Fund to run activity programs, sports and physical activity programs within disadvantaged communities. So some of our hubs are actually based in these, and it gives a structure for the older adults program within these hubs. But also we see a real potential in this mentor program for across all our target groups. It's not just for older adults. We see there's huge potential across all our target groups. And it also gives an understanding of why the older adults, it gives you understand for older adults why they're involved in the physical activity programs and where the research is coming from. And some of the older adults, as we found, actually got very, very involved in the whole program. We're going to see a 60-second video, and there's a longer video that we'll share the link with. Kira will share a link with hopefully later on. There's a video. One of the participants actually made a video on the whole process, and through some of the participants having a graph or a like for research, really got into it and are really become positive people within our communities that can champion what our programs are. And that championing is very important when we move out of what just to go for the Move for Life programs were, like the Bike for Life or the Women on Wheels or the Go for Life programs, into other mainstream type programs like swimming, aqua aerobics, exercise to music, Pilates, activator poles, walking, and other things that we can do in the communities, other activities. We now have this group of people and that can be our champions for this. From a practitioner's perspective, now Phelim kind of alluded to this a wee while ago, it's very, very important. Again, the learnings that we had as practitioners and our SDOs as practitioners and the tutors, it gives us a great understanding of, or it gives us a great possibility to fulfill the wheel of research and practice. So if we, maybe sometimes we only think of, yes, as a tutor or as an SDO, we go out and we just do our program. But if we can actually understand the why, the what, and the how of that research, of what research or why we're doing something, it makes our role more credible, and it gives us better understanding and probably gives us a better buy-in to what we're doing as well. It also takes away some of the barriers. It has taken away some of the barriers for us. in engaging with the academic research. Now, this is a huge project, and most of the stuff, like from what Paddy was talking about a wee while ago in the health economics to Enrique's research, some of this stuff is way beyond our understanding. But what it does is, when a piece of research comes out, or there is a research, there are results or understandings or knowledge created, sometimes the academics think, okay, we'll just go in and this will work, because this is what the research tells us, this will work. But coming to the practitioners is saying, actually, do you know what? The practitioners saying, yes, we understand what you're saying, but it just won't work in this setting. So that's what that's some of the key learnings has really been, is where there has been closing that circle. And then more enhanced experience for the participants, because they weren't just taking part in a physical activity program, they were actually partaking in a piece of research, and they were part of it. It was nearly a co-created experience for the older adults. And they're coming back to us saying to us that they've really enjoyed that, because they actually have a better understanding of what was going on. And the last line there, more supported journey as individuals and as a community. So within the communities, we were giving them more enhanced resources than we would have given in the past. And again, and it will in the future. And what this leads to is a more informed and enabled people, more active, more often. Next slide. All right. So that's the end of, and I said I would keep this 2 o'clock. I said I would keep it within time as much as I could. That's the end of our slide. Again, just to thank, I know it's been thanked at each presentation, but just to thank UL and all the other partners, funders, HSC, all the other partners for the program. It's been very fulfilling for us. And it had really opened the door for a better understanding, a better knowledge, and a more sustainable future for ourselves. And as Phelan was saying, that Leo Vradker was saying, it gives us understanding to go back and look for extra funding to create more programs and more research programs in the future.
Thank you very much, Phelan and John, and thanks for squeezing us in just in at 2 o'clock. So I'm just going to give a very short 1-minute summary of our afternoon here together, and then I'll let people get on for the rest of their day. So firstly, just to summarize the presentation from Catherine and Enrique, effectively showing that physical activity programs, all the programs to which Move for Life were added, work in and of themselves, and that Move for Life indeed may add value to those particular programs. Then a really nice presentation from Paddy, which showed that there is a health economics argument for these physical activity programs, and good evidence to show that they're a positive investment for the health return, even over a 6-month period. And lastly, a huge thanks to Phelan and John, who kind of brought the research to life. Gave us some personal stories there, mixed with some of the broader learnings that are of value, not just to participants, but also to the practitioners that work in this space. And just to mirror the thanks that John had, big thanks to UL and all of the team there, to Kira and to Marie for helping us with all the IT stuff in the background. I believe they're going to send you on links to videos and the slides and all that kind of stuff. Really just to finish to say, that all of this research and findings, and Phelan touched on this, is an opportunity for those who work in the sports sector and those who are participants to advocate for the value of these kind of programs and initiatives, to advocate for the investment into these kinds of opportunities, because we can make the lives of people in communities across Ireland much better by enhancing their physical activity experiences. That's it from me, folks. I'm going to wrap up. I don't know if Catherine does want to pop in just to say a quick goodbye, but if not, have a great day, and it's been a pleasure hearing you all this afternoon.
Thank you, everyone. Thank you for attending, and thank you, Benny, for a wonderful wrap up, and Phelan for a really interesting insight into the LSP experience.
Thank you, folks.